I'm Dr. Shari Barkin. I'm a professor of pediatrics at the Vanderbilt University Medical Center. And today I want to talk to you about putting science to work, how we can address childhood obesity. After a short stay in America, Michelangelo's David statue has been returned. In fact, we know that when we export a Western diet to anywhere in the world, it results in a body habitus like this, with what we call visceral adiposity. Visceral adiposity is associated with metabolic dysfunction and later poor health and disease outcomes. And yet, obesity is much more than just a surfeit of calories, just an excess deposition of fat. It's multifaceted and complex. And that means we have to think about interesting and multifaceted solutions to address the problem of obesity. And for childhood, it starts young. In fact, when we think about obesity in children, we know that it starts throughout your life's developmental course. And here we recognize that obesity is really a visible form of malnutrition in many cases. It's a lack of essential nutrients. In Stark County, Texas, in 59% of their elementary school-age children, they were documented to be undernourished. And in fact, 50% of those boys and 35% of those girls were already obese in elementary school. So often we get confused. We think excess calories. This is the problem, not enough physical activity. And these two things together lead to an imbalance for your energy balance and then leads in a linear way to obesity. But it's much more complex than that. So when we look at this picture, for example, you're going to see a lot of different phenotypes in babies. So you'll see all the way over a normal baby, all the way over here, and then next to that baby, a macrosomic baby. And then here, when you look here, here's another macrosomic baby, and next to that, a baby that had intrauterine growth retardation. So which of these babies are more likely to go on to have obesity, insulin resistance, and diabetes? A lot of people think that it's the large baby, the macrosomic baby. And in fact, that's true. But what also is true is that both that intrauterine growth retarded baby and the baby with macrosomia, we call large for gestational age, they actually have an equal risk for obesity, insulin resistance, and diabetes later in adulthood. So why would that be? That makes us ask different questions about obesity and makes us think about how we solve this problem in different ways. We know that childhood obesity really seems to behave like a chronic disease. In fact, preschoolers who were ever overweight are 5 times more likely to be overweight as adolescents. And this has a disproportionate burden depending on what part of the population you come from. Race and ethnicity makes a difference in these numbers. We see a higher burden of obesity, and especially obesity starting in childhood, early childhood, in African American and Latino children. We also know that overweight adolescents then have a 70% risk of becoming overweight or obese adults. This behaves like a chronic disease. So how do we address that? Well, we know we have to start early. We know we have to consider children in the context of their families and families in their context of their communities. And today I'd like to just talk about something innovative that we've done here at Vanderbilt. About 8 years ago, we started the Nashville Collaborative. This is a partnership between the Division of General Pediatrics and the Children's Hospital at Vanderbilt and Metro Parks and Recreation. And it's specifically intended to develop and test community-based, family-centered programs that measurably reduce childhood obesity. That means we have 4 themes that we all always strive to achieve. Our projects and programs and interventions, they should be family-based, they should be community-centered, they should be measurable, and they should be sustainable. We started this partnership 8 years ago, and we've developed and tested now 8 different programs. Why look at the real world like our learning lab? Well, it means that science benefits from practical research, that the community could benefit from an evidence-based, sustainable program, and if these things work together well, this should result in improved child health outcomes. So I'd like to give you 2 examples. What does that actually look like, and what did that result in? One of our projects was called Salud con la familia. That means health with a family. And here we wanted to examine a family-based, community-centered intervention to prevent and treat obesity for Latino parent preschool child pairs. We enrolled 100 Latino families with preschool-age children in 12-week sessions. Now, there's something really important to consider here. We know that many of our participants, they had the knowledge. They knew that they shouldn't be eating so many cheeseburgers. They shouldn't be eating pizza. They shouldn't be putting soda in their children's drinks or bottles. And yet, what they didn't know was the skill set to change those habits. So we designed this program to be very practical. We call this pragmatic. This was a pragmatic clinical trial. And we looked at how we built skills. How do you use what you have differently to result in better health? Something that surprised us was that about 41% of Latino preschoolers who enrolled in this project, and we never used the words obesity or overweight, were already obese or overweight. That was much higher than the national statistics at the time, which indicated that about up to 25% of preschoolers who were Latino were already overweight or obese. In our community, it seemed that it was more like 41%. What we found after we put together a 12-week skills-building session, 90 minutes, focused on the dyad, so not just the parent in service of the child, but the child in service of the parent, so that you work together. This is called reciprocal determinism. So if your parent is telling you and showing you how to eat healthy, often what happens is that child reminds the parent to do the same thing. That reciprocal determinism can result in improved health for both the parent and the child. So what did we find? Well, we found that a 12-week, short, sustainable, cost-effective program that was based in community recreation centers brought down overweight and obesity into the category of normal weight over a 3-week period of time, twice as often if you were in the intervention group. And what happened in the control group, as you can see here, is that short period of 3 months. In that period of time, what happened to the control group families? Well, more of them were becoming overweight or obese during a short period of time. Time matters, especially in that preschool period. And then most people say, well, what was it that worked? Why did it work? And we look into that black box, and we have many hypotheses. So one of our hypotheses is that we worked in families with both parent and child dyads to improve health of both sides of that dyad. We worked pragmatically in the communities in which they lived, so we looked to see what was possible. We also intentionally tried to build new social networks. So what you're looking at here is a social network diagram. You can see that both the control and the intervention group, when they started the study, they did have some connections with some of the other participants in the trial. But look what happened at the end. Both did increase their connectivity socially with other parents in the program. But in the intervention group, they increased the density of that connection by more than twofold. And what's interesting about social networks is as you connect new social networks, new ties, that's when it's thought that you can introduce new ways of thinking and new types of behaviors. Now, another thing that we recognize is that that was the social environment. What about the physical environment? We call this the built environment. This is defined as the neighborhood and community-made infrastructure and environmental context that affects our interaction with the environment. That's green space, that's sidewalks, that's traffic density, speed, and crime. And this affects how we use what we have, our environment, to either support good healthy habits or detract from them. And here's something that we learned from our participants. We learned that in addition to all those things that I just mentioned as built environment, something that really affected whether they were using the green space, and here in Nashville we have an incredible amount of green space, and we have had mayors that are really dedicated to enhancing the built environment. So we're fortunate. We have parks and recreation that are freely accessible. We have sidewalks, we have greenways, we have bikeways. But we found that parents with preschoolers were not sending their children outside to play. And why was that? Well, some of it had to do with the elements that I just mentioned to you. But we also learned that some of it had to do with stray dogs. So what you're looking at here, this is a Geographic Information Systems map. In the middle, you see the Cumberland River as our geographic divide. Up here, northeast Nashville. Down here, south Nashville. Those areas that are red have higher concentrations of stray dogs, and those areas that are green have lower concentrations. And just to give you a sense of scope, if you're in the red area, there are about 4,000 or more stray dogs. And if you're in the green area, there are 40 or fewer stray dogs. Now, what's really important about this, just as a discovery, which you learn when you conduct mixed methods research, both qualitative matched with quantitative, is that we have laws on the books for how to handle stray dogs. And we already have people hired also to handle stray dogs. So this helps you to see the problem in a different way and look at solutions in a different way. So we wanted to know, our next project, if we taught you how to use what you had better and different, would you use it and would you continue to use it? So we took those same families that participated in Salud con la familia, and we wanted to know 1 year later, after there was no programming, did you change your habits? Did you habituate using what you had better and differently to amplify and improve your family's health? So to do this, we looked at those families that had participated in Salud con la familia, and then we matched them to families who were also Latino, who also had preschool-age children, and who had the same geographic access to those parks and recreation centers. And we found that if you were exposed to Salud con la familia, where we actually taught you how to use your built environment, 2/3 of those families were still using their recreation center more than once a month. And importantly, as I mentioned to you, in terms of improving health not only for the parent but for the child, that what we saw was that same 2/3, they were bringing their child with them to be physically active, not leaving their child in childcare, but going there to be physically active together. And what do we mean by more than once a month? Well, our participants showed us that it was really about 50% of them meant once a week or more. And that's how you can improve the public's health. That's how you can improve physical health, regardless of what your BMI is, by this type of daily or weekly physical activity. Importantly, for those families who had exactly the same geographic access, because they weren't sure how to use what was in their community, 70% of them said they actually never used it. We're fortunate again in Nashville that you could walk through those doors, pay $0, and still be physically active with some of that programming, and other programming that would just cost dollars, maybe $2 or $3 for a class, so really accessible economically and geographically. But if you didn't know what was in your community and you didn't know how to use it, then you couldn't use your physical built environment to get to better health. So, what did we learn? We've learned that if families are healthy together and make this a habit to use what they have better and differently, that it results in sustained change in both the parent and the child. And it looks like this, with teaching kitchens in community centers that are now part of their programming, regardless of whether we have a grant or not. And it looks like healthy families, and it looks like happy children. So that's what we mean by putting science to work.